have to exclude those or say, well, it's a bit of both or something. Then the ecological approaches, which I've been particularly involved with, and these are assessments designed to predict everyday problems. So a poor score on a traditional test doesn't tell us much about real-life problems. And the examples I've been involved in, or some of these, the Rivermead Behavioural Memory Test, a new version out last year, the Test of Everyday Attention, one of Ian Robertson's tests, the Behavioural Assessment of the Dysexecutive Syndrome, and the WIM, the Wessex Head Injury Matrix that I talked about earlier this morning. But of course we also use a psychometric approach in the development of those tests. We're getting a big sample, we're establishing norms, we're looking at reliability and validity and so forth. Then emotional problems, theories for those. Well, I already said this morning they could be due to neurological factors, psychological factors, and psychodynamic factors, and this is based on Gaianotti's taxonomy. But the kinds of emotional and psychosocial problems we see in brain injury rehab, anxiety and depression, anger, that's quite a common one, I think, anger outbursts, fear, that comes up, distress of various kinds, grief, people grieving for what they're lost, and certainly their families do, poor self-esteem, very frequent, lack of confidence, and so on. So these are the kinds of problems we might see. And in the UK, one very, very influential book, that's an American book, but it's really taken, all clinical psychologists do this in great detail now in their training, is Beck's book, Cognitive Therapy and Emotional Disorders. And cognitive behaviour therapy, or CBT, has become one of the most important and best validated psychotherapeutic treatments, which has led to the development of clinically relevant theories for depression, anxiety, panic, obsessive-compulsive disorder, and phobias. And more recently, it's been employed in cognitive behavior, in brain injury rehab. So CBT is now widely employed in neurological, neuropsychological rehabilitation centres, and this is Hugh Williams there, taken in Pavlov's office in Russia on a visit there. But this is Hugh Williams, who's done a lot of this work looking at CBT with people with brain injury. Now, this is the example I skipped over this morning because I just wanted to give you another example of a young woman treated at our centre to try to illustrate how important it was to deal with her emotional problems alongside the cognitive problems. So she was 19 years of age and she was attacked on a train. And because the knife went into her right parietal area and not into the brainstem, she did not lose consciousness. And she was able to give an account of what had happened to her. And this is part of her account. There was a lot of people on the train, and people got off, and I was alone. I was engrossed in a book. I saw a man go past. He smiled and went into the next carriage. He came back 2 minutes later and walked past. And after 30 seconds, I felt pain in my head and a weight as if the carriage had fallen onto me. I got up and realised something terrible had happened. I went into the next carriage and another man told me to sit down and he'd get help. And he told me to stay still. I put my hand up and felt the knife. I asked if I'd been stabbed and I asked if I was to die. He said no, and he'll get help. And at the next stop, an ambulance arrived and took me to hospital. So she's fully conscious throughout this horrendous attack. It doesn't happen very often, but this was happening in a very safe, wealthy part of Britain. But you can imagine, after that, emotionally, she was in a mess. And this one of the scans, I think have I got the, right, there's another one there. Now, when she first came to us 9 months after the injury, she wouldn't look at anybody. She avoided eye contact. She was having lots and lots of nightmares, post-traumatic stress disorder, tremendous fear for her family. She thought they were all going to be killed. Socially incredibly isolated and withdrawn. So she was attacked on the train. The knife entered the right parietal area, leaving her with cognitive and emotional problems. The cognitive problems were memory and visual spatial deficits, and the emotional problems were avoidance, depression, anxiety, and post-traumatic stress disorder. So like all our clients, she attends groups at the centre. She has individual psychological support as well, and individual therapy for other things. She was taught to use a memory system. She went to the Understanding Brain Injury group, which is one of the main groups for increasing awareness of what's happened to them. And gradually engaging in activities. So one of her long-term goals was to travel by train alone from Ely to Cambridge, which is a 17-minute journey. Now, of course, that was one of her terrible fears. She couldn't go on the train because of what had happened to her. So the first sub-goal was for her psychologist to go with her on a bus for one stop, sitting at her side. When she could do that, the psychologist sat behind her on the bus for one stop. Then he sat at the back of the bus. Then they increased the number of stops. Then he drove his car behind the bus. Then she started on the train with him going with her for, and so on. And she achieved that goal by the time she left us. And when she left our centre, she was looking people in the eye. She was using her compensatory systems. She's no longer withdrawn and depressed. Her nightmares had reduced significantly. There's a whole chapter about her in our new book that I've got in your extra reading after my abstracts. And she's Caroline in the book, a whole chapter about her. But it was, I think, a good example. If we just dealt with the cognitive problems and left the emotional problems, I don't think we'd have got anywhere, because they were the ones that were more important and getting in the way of her rehab. Now, Yehuda, I can go on, or I can cut this short.
We've gone over our time a little bit. We started late, but we don't have very much time. So perhaps you can summarize.
I'll just come to all right. I was going to talk about models of recovery and plasticity. Nice Greek word there somewhere. Diaskisis. From the Greek meaning shocked throughout. Now, where's the man that said we should be using nososagnosia? Is this one correct? That one's okay, right, okay. So I won't say about that. Ian Robertson, great friend of mine, but I think he's not got it entirely right. Yehuda and George, holistic approach.
Sounds good for your workshop.
I know, I've got a lot more for the workshop, different things. My model, which I won't go into, but it's complicated. This was done in a fit of pique against Max Coulthart. Max thinks we only need one model to treat people with reading disorders or language disorders, and I think he's got it all wrong. So I came up with this complicated model, and this is Max's bit there, and he's totally ignored and not taken into account all the rest of the things we need to know when we're planning a rehabilitation program. Conclusions, right. Current neuropsychological rehabilitation makes clinical and economic sense. It is possible to combine theory, scientific methodology, and clinical relevance, like the errorless learning studies, the NeuroPage studies, and things like that. We've done it scientifically, absolutely properly. We've been driven by theory, but all the things the patients are learning are clinically relevant. I'd like to just try to tempt some of you to come on our trek to Transylvania, northern Romania, next August, collecting money for the Encephalitis Society, of which I am the president, and thank you very much for your attention.
Thank you, Professor Wilson, for making this very important bridge between models and